Let's go ahead and get started. Again, my name is Matthew Menendez with White Plume, and let me tell you what I hope to accomplish in the next 50 minutes or so with our time together. The first thing that we have to answer, and this probably isn't for you, but there may be other people in your practice who share this concern. And the question is, why in the world are we still talking about ICD-10? I thought we did that last year, right? Thought that was in the past. You shouldn't have to worry about that anymore. So I'm going to try to address that and answer those types of questions, because I think there are people out there that make the mistake of thinking that ICD-10 is over and done with, and we won't have to deal with ICD-10 in 2016. And then we're going to take a look back and say what happened in 2015. What went well with ICD-10? What did not go so well? Good news, bad news, and so that we can use that to then look to the future to say, what do we expect to happen in 2016? What's the outlook? What are some of the risks facing orthopedic practices? And then with that in mind, how do we mitigate those risks? And again, the two big things that we want to focus on are first and foremost physician productivity. Remember, we've said this before, if your doctors aren't taking care of patients, nobody else in the practice is doing that. If your doctors aren't generating revenue for the practice, nobody else is doing that. We've got to make sure we let our doctors be doctors. All of the studies about physician job satisfaction point to that. They feel like they've been turned into data entry employees, and that's not going to make our patients better. But at the same time, we do have to balance that with the revenue cycle need, right? We have to get our claims paid, and we have to be able to do that quickly and completely and the very first time. And we need accurate coding in order to do that. So how do we balance those two needs? We're going to talk about how to do that. Again, I'll make sure that I leave time for questions and answers at the end. For those of you who may be joining us a few minutes late, welcome. You can use the questions panel on the far right if you have questions as we go. No need to hold those until the end. So let's start with the end in mind. What do I hope you can take away from this webinar at the end of our time together? The first thing is that I hope you'll realize is that ICD-10 is not over. October 1st was not the finish line for ICD-10. October 1st was the starting line. That's when we started ICD-10. Yes, we had put in years and months of planning to get to the starting line. But we are going to use ICD-10 for at least the next 5 to 7 years. And with that being said, you're going to have to continue to make adjustments, right? All of the planning that went in place was very, very good, but you've got to make adjustments. The payers are going to make adjustments, and you need to be able to respond to those. One question that I hope you'll be able to answer, if you don't know this already, is what percentage of specified codes and unspecified codes is my organization using? That's a very important thing to know about how at risk your productivity and your cash flow is in 2016. So we're going to talk through that. We're going to talk through that, show you some tools that are available to find that out. So then with that information in hand, you can make sure that your processes are producing the types of results that you want. And if you need to make changes, make sure that you do that in a way that protects your doctor's time and gives you the data you need to get claims paid correctly the very first time. So that's what I hope you'll take away after the end of this webinar. All right, so let's go back to the beginning. Why are we still talking about ICD-10? Right? It was the #1 thing that everybody had on their mind that they were worried about in 2015, right? And there was a lot of talk about all of the risks associated with ICD-10. There was a lot of talk about what it would do to physician cash flow, right? A lot of consultants recommended having a line of credit in place that would cover 3 to 4 months of operating expenses. So if your claims weren't getting paid, that you could still pay all of your expenses while you were sorting through that. Medicare predicted that denials would double or triple because of ICD-10. That was all of the concern in the lead up to October 1st. And then what happened? denials didn't increase one bit, right? There may have been some pockets where people saw an increase in their denials. That may have happened in your practice. But when you look across the industry as a whole, it didn't move one bit. Let me share some data with you that Medicare published 30 days into ICD-10. They compared denials in October of 2015 to the historical baseline. And two things worth noting here. At the very bottom of this slide, you'll see that the total denial rate didn't move at all, 10% and 10.1%. No change. And then if you look at the very top, you can see that the claims volume didn't change either, right? Some people would say, well, maybe the reason it didn't get denied is the people that were really struggling with ICD-10 weren't even able to submit their claims. It doesn't look like that's the case. The data just does not show that. Okay, so we have to ask ourselves, if Medicare expected denials to double or triple and they didn't increase at all, why? What caused that? And I can think of a few possible explanations. Number one, maybe ICD-10 wasn't as hard as we thought it was, right? I think that's relatively unlikely. We still moved from 16,000 codes to 69,000 codes. A huge shift. This was not another Y2K type of event where it was all hype, right? And then it really became a non-event. I don't think that's the right explanation. Another possible explanation is maybe the provider community, physicians, hospitals, they did a much better job preparing than Medicare had expected. They are providing the rich detail available in ICD-10 at a much higher rate than Medicare expected. You know, that means all of our doctors spent all of their weekends in 2015 memorizing new ICD-10 codes, right? I mean, it could have happened. That's a possible explanation, but I think it's probably unlikely to explain why October 1st was a complete non-event. Denials didn't move. I think the most likely explanation is that we have not seen the real impact of ICD-10 yet. Right? And this may be something that you are aware of, but it may be something that you need to explain to some of your physicians or some of your colleagues in your practice who don't understand this. Right? So let's look back at what happened in 2015, see why we haven't seen the real impact yet. The good news about what happened in ICD-10 is that we survived. Right? October 1st was not an industry-wide meltdown. Right? It was not another healthcare.gov for Medicare and the other payers. Most people were prepared. That means payers, that means clearinghouses, that means vendors, that means providers. Right? We were able to submit claims and get those claims paid in the aggregate. That doesn't mean that there weren't hiccups and problems for certain practices, but for the most part, claims got paid and patient care didn't suffer. Right? And how did all of this come true? I think the linchpin was in July when CMS said that they would offer the grace period, that they wouldn't deny claims because of lack of specificity. That was the good news from 2015. What about the bad news from 2015? Well, the bad news is we start in the exact same place, right? The bad news is that CMS delayed the denials for those unspecified codes. That grace period allows for some bad habits, right? It lets people who don't have particularly good workflows be successful. And the problem with that is it's a silent killer. It gets into your process, it gets into your workflow, and those bad habits are reinforced. At the same time, you may have practice leadership who has raised the victory banner of ICD-10 and have moved their focus on to other areas of the practice. And so when the payers do begin to crack down and do begin to require that additional detail, that's when you might be at risk. That's why we want to say that ICD-10 has only just begun and that you need to continue to evolve your strategy. right? Let's look at what CMS said. You remember they did that joint press release between Medicare and the AMA, and basically what they said was that CMS would not deny claims for lack of specificity, and that they would apply that to the PQRS and value-based modifier programs as well, and that they wouldn't require that level of specificity before October 1st, 2016. Now, this was Medicare only. It did not apply to Medicaid. It did not apply to the commercial carriers. However, most of the other payers have followed suit. Most of the other payers are not yet denying claims for lack of ICD-10 specificity. CMS further clarified this position to say that as long as you were in the right code family, those are the first 3 digits of the ICD-10 code, that they would pay the claim. And there are only less than 2,000 ICD-10 code families in the entire ICD-10 code set. So you can still be very vague and get those claims paid for now. Now, we don't know if and when and how the commercial carriers will start to enforce this. Will they wait until October 1st? Some may do that. Will they push ahead and do that earlier? Some may do it that way. We don't know, but the problem that this presents for most practices is this false sense of security. And let me explain this. What happened, if you can put yourself back in the mindset of Thursday, October 1st, right? Everybody was holding their breath to see what that day would be like. And on the very first day, you would see press releases and tweets from practice management vendors and EHR vendors saying, we have been successful in ICD-10. They had pictures from their war rooms, right, where they're saying, victory, we have won on day 1. And a lot of people said, well, not so fast. Hold on, let's wait and see and make sure that we're able to submit claims correctly, right? And so they did. And about a week and a half later, you had the clearinghouses saying, we're able to successfully transmit this information to the payers. And the payers would say, we're able to successfully receive this information, right? What they're trying to say is if there are any problems later, it's not on us, it's on somebody else. But you had a lot of people who said, well, hold on, let's wait and see what happens when these claims actually get adjudicated. Make sure that it can go all the way through that process and that claims can get paid. And lo and behold, 30 days later, which is when you see this press release from CMS, claims were being paid correctly. It means that the plumbing is all connected. Data is flowing from the practice to the clearinghouse, to the payer, and claims are being paid. But what we don't know yet is the quality of the data flowing through those pipes, right? So the practice management vendors, the EHR vendors are saying, we did it. Payers are saying, we did it. And if there are ever any problems later, guess who that comes back on? Comes back to your revenue cycle process, back to your physicians. And that's why it's important to know what quality data is flowing through your pipes, right? What ICD-10 codes are you using? Now, remember the lead up to ICD-10? Everybody liked to make fun of some of those crazy codes. Everybody remembers this, right? This was one of my favorites that everybody liked to make fun of, and it makes for a funny picture, that flaming water skis encounter. In the fourth quarter of 2015, we looked at some of our largest clients. It looked at 2.8 million coded diagnoses. You want to know how many times we had a client use that particular code? A grand total of 0. Nobody used it, right? Same thing about unspecified spacecraft accident. Nobody used it. These were the codes that everybody was worried about, everybody was paying attention to, and nobody uses those codes. But we also found that over 40% of providers had used some codes that were very unspecified, like this one. Over 40% of the providers surveyed used T14.8 at some point in the fourth quarter. And you can see that is very, very vague. other injury of unspecified body region, right? Everybody knows that unspecified codes existed in ICD-9. In fact, there are more unspecified codes in ICD-10 than there were in ICD-9. Even though we have all of these new codes, unspecified codes are more prevalent in ICD-10 than they were in ICD-9. But the big difference is, in ICD-9, unspecified codes were not particularly risky. They were payable diagnoses, and a lot of people used them on cheat sheets, on fee slips, on encounter forms to make their templates faster for providers. And there are significant risks to using unspecified codes in ICD-10. There's a short-term risk and there's a long-term risk. Let me try to address both of those briefly. The short-term risk of using unspecified codes in ICD-10, and you'll probably see this if you're not seeing this today, you'll probably see this in the next 6 to 18 months, is that claims will get denied. The payers will begin to crack down, right? This is the entire reason they wanted to move to ICD-10 in the first place. The payers, the reason that they advocated for ICD-10, the reason that they invested millions of dollars rewriting their adjudication process for ICD-10 was because they want the more granular code information. They want the more detailed diagnosis codes on their insured patient populations. And if they don't get that, they are eventually going to deny those claims. Sure, they're allowing a grace period. This is new for them as well. And they want the transition to be successful. They don't want an industry-wide meltdown. I think that they are doing this in their own financial best interest. And when they start to deny the claims, you'll see your accounts receivable getting longer. You'll see billers and coders have to spend time going back to the physician, back to the clinician, back to the note, looking for additional detail. Tell me more about the disease stage. Tell me more about the anatomical location, right? That'll slow down doctors. That'll slow down billers. That'll slow down your revenue cycle. We are already seeing that in some places across the country. Seeing clients that are in Georgia where Georgia Medicaid is already starting to crack down for lack of specificity, right? They really ramped that up in December and January. Seen one payer in Texas, one payer in Arizona where they have done that as well. So that is coming. And it may not all happen at one time, right? All the payers may not do that at the same time. They may phase that in. They're each going to do that on their own timeline. That's the short-term risk that you'll probably see over the next 6 to 18 months. The long-term risk, which is a bit harder to peg as far as when you'll see this coming to your practice, is that as we transition away from fee-for-service, as we move into a value-based reimbursement world, pay for quality, pay for performance, call it whatever you'd like. But in that world, it is all about the expected outcome compared to the observed outcome. How sick is your patient? What are the comorbidities, right? And if you don't document it and you don't code it, it did not happen. That's why the specificity that you use on your diagnosis codes is so important in that world. The payers are already gathering the data on this. And if you want to be able to protect your reimbursement, to keep it from declining, you have to get better at coding more specifically. We're already seeing this for some clients that are involved in ACOs or some Medicare Advantage plans where they're using the HCC codes. These are the higher acuity codes. That's why it's important that you code specifically and don't just use a bunch of unspecified codes, even if those claims are getting paid today, right? So there are unspecified codes all over the place in ICD-10. They carry short-term risk and long-term risk. The question that I get from a lot of people is, well, how prevalent is that? How frequently are those being used? And let me share two different sets of data source on that with you. The first one is from the National Institute of Health. They publish every year the outpatient frequency diagnosis coding. They have not published 2015 yet, so we can look at the 2014 data, which of course contains ICD-10 codes. When you look at the top 200, the most frequently used codes in the outpatient setting, right? Nearly a third of those codes are unspecified codes. Very, very common. Very, very common. And if you take those codes and convert them into ICD-10, it gets even worse. Over 40%, right? Nearly half of the most commonly used codes would be unspecified. Let me share another source with you. This one, there's some sample bias in it because it's only coming from some of the largest white plume clients. So these are large groups that care about being specific in their coding, right? They may have some resources that some of the smaller practices may not have. But in the fourth quarter, we looked at nearly 5,000 providers and 2.8 million coded diagnoses, and the unspecified rate in ICD-10 was just over 10%. That was the average. Obviously, some were better, some were worse, right? So you could be anywhere, and it's a pretty big range in the 10% to 40% range. And I think it's important to know what that is for your practice. And I'm going to talk about how to do that. But let me give you just a couple of examples first, some of the most commonly used unspecified codes, and you'll start to see why those are going to cause problems for us later in 2016. The first example is osteoarthritis. Okay, this code M19.90, you can see that it's unspecified, right? If you were to look that up in the code book, you'd see 95 other ICD-10 codes for osteoarthritis, right? And in this case, we were seeing practices using unspecified osteoarthritis on 11% of the total encounters that had osteoarthritis on it, right? So right in line with that average. Unspecified, this one's unspecified in multiple reasons. You can see it has unspecified twice in the description. That's always a warning sign. Those are probably more likely to get cracked down on first by the payers. It's unspecified as far as the type. Is this primary osteoarthritis or is it secondary? If it's secondary, is it post-traumatic? It's unspecified as far as the joint. It's in the shoulder, the knee, the hip, foot. And it's also unspecified as far as the laterality. All right? You can see that claim may get paid today, but may not be paid in the future. Another one that's commonly used, probably won't see this in orthopedics, but unspecified malignant neoplasm of the breast, right? 54 codes in ICD-10 if you were to look that up in the code book. But you can see the unspecified code is being used much more frequently here. And the problem is it doesn't tell you which site, right? Which quadrant. It doesn't tell you which breast. That's going to get denied. Another example that was commonly used, unspecified otitis media, unspecified ear, right? 80 other choices. Over half of the time, practices were using the unspecified code here. This is a very common problem. It doesn't tell us if it's acute or chronic. It doesn't tell us which ear we're talking about. So think back to our process. Think back what happens. How does that data flow in your organization? In some way it goes from the physician to the billing team, to the practice management system, out the door to the payer, and the claims are getting paid. All of that works for you now. Is that workflow, is that data good quality data? Because if it's not, when those claims start to get denied, we go back to the beginning of this process, where we have billers asking doctors, doctors taking time, being frustrated that they're not spending that time with their patients or with their families, and claims aren't getting paid. right? How big of a problem is this? Again, I'll share 2 studies with you that were done trying to quantify what the risk would be for a practice. The first one was done by Nachemson Advisors, and they separate this into a couple of different dimensions. Number 1, small, medium, large practices. Small practices are 3 providers, medium practices are 10, large practices are 100 providers. And then they also put pre-implementation and post-implementation costs. The pre-implementation costs are in the rearview mirror, right? We've already done that. Most people make the wrong assumption that the post-implementation costs did not happen to them. Most people did not see a productivity loss. Most people did not see payment disruption yet. Most of those costs are still in front of us, not behind us. On the productivity front, once you lose that time, you never get it back. You never get it back. It's gone forever. On the payment disruption, yes, if you've got a good process in place, you can eventually get those claims paid. It just may take longer and more resources than you'd like. Right? That's what we've got to be careful about. That's what I want you to guard against, because it's still ahead of us, not behind us. Another study that was done, this one was done by the advisory board, looking at Canada's transition to ICD-10, and look what they put front and center. Front and center, they put physician productivity loss, projected to be 10 to 20% because of ICD-10. If you want to get underneath those numbers a little bit better and understand what's happening there, it was coders, it was billers going back to the physician to say, I need more detail here. I need more information. Can you be more specific? Tell me more about this. And those questions back to the doctor were taking on average 45 to 90 minutes per provider per day. Even if you cut that in half, where your doctor is going to find the time in their busy schedule to spend 22 to 45 minutes per day answering coding questions. That's not what they're trained in. That's not what they're good at. That's not what they enjoy doing, right? But it's a necessary evil if you want to get those claims paid. That's the risk that's ahead of us. You know, and it's not just for the doctors, right? It's the billers and coders as well. They're the ones that are going to have to manage that process. They're the ones that are going to have to ask the doctors for the information and follow up on them when they haven't responded, right? They're the ones that are going to have to resubmit those claims and do the research, right? Coder productivity, biller productivity that you see on the far left is expected to decrease during the first 12 months. I would put that as the first 12 months that they're actually required to be specific in ICD-10, right? So it may be a longer transition than expected if some of the payers stretch out the timeline that they start to require that. It may make the decrease in productivity not as deep, but it may make it last longer, right? And their decrease in productivity is not expected to be permanent. They will regain some of that as they become more proficient, as they become more familiar with the code set, but they'll probably never get back to their pre-ICD-10 levels of productivity. What you see on the far right of this slide is the rework productivity, right? And that fits with the Medicare prediction that denials will double and triple in the short term because of ICD-10. Again, we haven't seen that yet, but we expect to see that over the next 6 to 18 months. All right, now I know a lot of that seems very high level. We're going to try to get down closer to the real world and how this would impact your practice, right? So what I would encourage you to do is know what codes you're using, know what your unspecified rate is, and what risks that presents to your practice. Okay, this slide we put together for a 10-provider practice on average to say what does the unspecified rate mean for them. Now, I know there are a lot of numbers on here, so let me walk through that for you. Okay, we'll look at the example of a 10% unspecified rate, right, since that was on the low end of what we expect practices to see. So in a 10-provider practice, Each provider is seeing 30 patients a day. Each encounter has 3 diagnoses, right? That's 3 times 10 providers times 30 patients. That's 900 diagnoses per day. 10% unspecified rate means that you have a potential denied claims of 90 denials per day for that practice. Right? If each of those produces a question back to the doctor, right, that's 9 questions per doctor. And if each question requires 3 minutes to read, research, and respond, you're very quickly into that 27 minutes per provider per day range, right? And that's an unfunded mandate, right? The requirement to be more specific in ICD-10, no additional reimbursement comes from that. There's no bonus, there's no incentive. It is strictly a cost borne by the practice, borne by the provider, right? And I think that's the big risk. It doesn't have to be that way, but you've got to get out ahead of this so that you're not chasing this at the last minute, right? If you use the medical economics figure of $25 per denial, that would be a cash flow risk of just over $2,000 to the practice per day. So you can see that adds up very, very quickly. Now, if any of you saw 90 denials or 90 new denials in one day, sirens go off, you would raise your hand and say, what is happening? But it probably won't be 90 in one day. And that's part of the bad news about what Medicare did. When they delayed that, when they delayed the impact of ICD-10 and allow all the payers to be on their own schedule, right, it means that this will be slowly phased in over time, right? Slowly phased in over time. I heard somebody once talk about what happens if you put a frog in a pot of boiling water. You guys know this story? If you put a frog in a pot of boiling water, he jumps out. But if you put a frog in a pot of warm water and slowly turn up the heat, he doesn't notice the difference until it's too late. And that's what can happen to a practice who's not paying attention to this. It's not 90 new denials in one day. That happens slowly over 6 or 12 months. And then you look backward and say, what happened? And that's why it's important to know what risk level your practice has. And so that's what I think the big questions for 2016 are as it relates to this, is how at risk is my practice? And then once I'm equipped with that information, how do I make sure that we've got a good process to get the right code the first time without turning my doctors into coders? So what I would recommend doing, if you've not already done something like this already, is do some analysis of the codes that you're using. We've been doing this for our clients, and the data is very powerful. Powerful to share with your doctors, powerful to know so that you can prevent some of these problems. The names on this have been changed to protect the innocent, but what it tells you is here's what the unspecified rate is for your practice. And here's what that means as far as denials and time for the physician and daily cash flow risk for the practice. But then gives you the detail at the bottom to allow you to compare your doctors so that you can see down at the very bottom, Andrew Jackson, he's the second best in the practice. His unspecified rate is only 2.7%. But look at Thomas Jefferson. His is 17%, right? We see a wide variety from one doctor to the next on this. And providing them with this information is usually very helpful and eye-opening. It's usually not that doctors are opposed to being more specific, but they've got to be able to do that in a way that doesn't take them more time. So knowing this information is very helpful. And if you'd like for White Plume to do this for your practice, right, let me know. Use the questions panel for that, and I'll have somebody follow up with you and get the data that we need to run this analysis. There's no charge for that. We do that as a free service, and I certainly recommend doing that if you haven't already. The other thing that we send you is data on the most frequently used unspecified codes, so that you can see where your big problems are. You can see how many times you use that code, and you can see the more specific alternatives that you should probably be using. Knowing the data is powerful so that you can do something about it now when you're still in a penalty-free environment. So that you can see, are you on the low end of the unspecified rate spectrum, or are you on the high end? Are you at 10%, or are you at 30%? Because knowing that number has a big impact for how at risk your revenue cycle is for 2016. And then you can go about the business of saying, how do I be more specific here? And we've seen clients do several different things in order to try to be more specific. We've seen clients that have said, we're going to hire certified coders, right? We'll do clinical documentation improvement for our providers, and then, right, we're going to have our coders code from the note. The problem that some people have run into with that is that it's expensive, right? Coders are getting more expensive, they're getting harder to find, and they're getting less productive. It's going to take them longer to do that in ICD-10 than it did in ICD-9. That's why that doesn't work for most private practices. It's simply an economic decision. But I've seen some people do it, so I wanted to make sure that I bring that up. Another strategy that I've seen some people take, and it works very well for some, and it works very poorly for others, is I'm going to get all my doctors to do this through the EHR. Right? We've talked about this before. One of the reasons that you hear complaints from practices where this doesn't work well is because the doctors say it takes too long. They're in a hurry. They don't want to be data entry employees, and that's why it's important to know how that's handled in your EHR, right? It's not enough just to be sending out claims that have ICD-10 codes on them. You need to know what codes you're using, because the way that it works in some systems is that it's through a code search mechanism, and I'll show you some examples, but oftentimes the first codes on the list are not the ones you want to use. Oftentimes those are unspecified codes. I'll give you some examples, but Google has basically trained us to expect the answer to be at the very top of the list. And that may work when you're Googling for information, but when you're searching for a code, right? When you're searching for osteoarthritis, the search results at the top of the list may not always be exactly what you're looking for. I'll show you some examples of that, and that'll help you. Another way I've seen some clients try to handle this is through cheat sheets or through a crosswalk, right? They're looking it up online. I saw a practice that they had built in a cheat sheet where they had tried to list out all of the codes that they wanted to include there, right? To try to make it easy. But again, that cheat sheet would be very, very long if you included all the specific choices. So a lot of times people use unspecified codes as a shortcut, and that's the problem. Typically people who are using this type of solution, we see much higher unspecified rates. And again, that behavior is being reinforced right now because it's working. It's not causing denials yet. All right. And then obviously the last example, what we've seen people do is the electronic superbill called Capture, doing that in a way that has a nice balance between making it easy and fast for the doctor, but getting the right code for the payer, making sure that you get the right code the first time so that the claim gets paid the first time. I'll show you an example about that osteoarthritis, right? If you wanted to go through and do a search, you can certainly type that out, do that, and you'll see the search results. But does anybody know which joint is most commonly coded for osteoarthritis? It's the knee. It's the knee. And you'll notice on this list, Knee's not even on the first page of the search results. You'd have to scroll down to find it. And you've got to read through all of those descriptions to find what you're looking for. Or use the drill down on the far left, right, in order to get to that particular code. That's the problem. That's the problem. That's why you've got to look at how your system's set up and how do I make sure that I include just the right codes that I want. Right? We've seen some of our clients, what they've done with osteoarthritis in that pop-up is they take out the choices for unspecified, right? So you're not even going to use an unspecified knee, right? You're not even going to use an unspecified knee because there's no such thing. It's either the left knee or the right knee, right? They also default it to the knee. You can switch to another joint if you'd like, but because that's the code that they use most frequently. They're trying to minimize the number of clicks for the provider. Okay. Now, let me, one of the questions that I often get when we're looking at the ICD-10 unspecified analysis is, will I ever get that number to 0? Will I ever get my unspecified rate to 0? And the answer is absolutely no. There are appropriate times to use an unspecified code, right? If you haven't done the MRI and you don't know what type of tear you have in the knee, you cannot code for a bucket handle tear, but you can code the right knee, right? You can code the right knee. So you want to be as specific as you can. Obviously, your coding must be backed up by your documentation. That is still always true. True in ICD-9, true in ICD-10. All right? So I'll show you one more example of how that works from a code search perspective and where some of the problems come in. Another example that we looked at was that malignant neoplasm of the breast, right? And again, you can do the search results. You can see all 75 results here. But 99% of the time when you have a malignant neoplasm of the breast, it's for a female patient. And so you can see right here, half of the search results, right, that I have to read through to choose the one that's most accurate, don't apply. They're not what I'm looking for. And so that's why clients that use that electronic superbill have customized it to default it to the female. So they can change it away from that if they need to. But 99% of the time, it minimizes the number of clicks and also shows them, hey, here's another code that you need to use for the estrogen receptor status. Is it positive or is it negative? Right? Very similar to some of the causation diagnosis codes, right? You remember the E codes in ICD-9? They would show the place of injury, right, or the activity that was going on when the patient got injured. Remember, those E codes, Medicare's guidance on that was if you're not using E codes in ICD-9, there's no new national requirement to use E codes in ICD-10. That may change in the future, right? But right now, there's no new requirement to use those codes in ICD-10. All right? So what you want to do is look at the data, understand what your unspecified rate is, review your workflow. Is it producing the type of results that you want, right? Or is it producing bad results and you need to change your process? All right? So we've talked a lot about the provider. How do we make that productive for them? But we also have to look at the payers and look at the revenue cycle, because it is going to be a big change for them as well, right? We're still in the fee-for-service world, and you still get paid for CPT codes today, just like you did in ICD-9. But you have to have a diagnosis code that makes it medically necessary. That part has not changed. Now, it's not as easy as just submitting a claim. You still have to jump through the hoops and hurdles from the payers in order to make sure that that claim gets paid completely and correctly the first time. And just to make it even one more layer difficult, not all payers do that the same way, right? Some payers, Blue Cross wants it coded on one line with an LTRT, and Medicare wants it on one line with a 50 modifier, right? That still holds true. But a lot of you may have had people who knew the ins and outs of that game in their head. They experienced that in ICD-10 for over 30 years, and they knew exactly what the payers wanted, and that's how you made sure that your cash flow continued to come in day after day, week after week. Unfortunately, that head knowledge went out the door the night of October 1st, right? We left ICD-9 behind, we moved forward with ICD-10, and the payers have not fully implemented all of their edits in the ICD-10 world yet. We know they're not denying for unspecified codes. There are some places that still haven't put out some of their LCDs yet, right? So yes, ICD-10 was a one-day change, but the coding impact has been delayed, right? So we still have a lot of that change in front of us. The payers have never done this before. They're going to be learning as they go, and they're going to be making changes to their adjudication process. They're not going to do that all at the same time. They're not going to do that on the same schedule. They're not going to do it in the same way. And that makes it very difficult for a practice to keep up with. The volume of change to that process will be much higher than anything we have seen before in our careers. The volume of change will be significant. And if that's what the new world's going to look like, you have to ask yourself, how are we going to manage that? What should our process look like? What types of tools do we need? Who in our organization owns that responsibility? And maybe the more difficult question is, what happens if we don't do a good job of that? What happens to our cash flow? What happens to our billing staff? What happens to our clinicians when we have to go back and ask those questions? Because most of that change is still ahead of us, not behind us. One of the things that we recommend doing, and anybody can do this, is a process called closed-loop denial prevention. What it says is it recognizes that payers will continue to change the rules. I can't rid the world of denied claims. But when I see a new denial or I see a new policy that comes from my payer, what I'm going to do is I'm going to go back to the beginning of my process. And I'm going to do a root cause analysis to find out what went wrong. And then how do I build in a new rule to make sure that that doesn't happen again, right? Fool me once, shame on you. Fool me twice, shame on me, right? That way, the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, we need to make sure that we're going to identify that so that it can be corrected and do that the same way every single time, right? Whether it's my most senior certified coder or my newest billing clerk, right? You can do that on a notebook. You can do that in a binder. You can do that in somebody's head. Obviously, if you can do that through a software tool, that's much more powerful because it institutionalizes that knowledge for your practice. You know, one example of what we've seen a client do is they've built in a rule that says, look, when I see a patient that uses that unspecified osteoarthritis of the knee code, I want you to stop me and remind me so that we can take a look at that. And if you look at the way that this rule is built at the very bottom, it tells you that the payer doesn't deny the claim, but they pay that at a reduced rate, right? That's a much trickier problem to identify and solve if you don't have a good process in place to get it right the first time. It's not going to show up on a denied claim report, right? And again, if that's something that's phased in slowly across your payers, you may not notice it until it's too late. We have seen some payers that have gone too far, in my opinion, where they are denying claims for unspecified codes when the unspecified code is being used correctly, right? I'll give you an example from a Georgia Medicaid pediatric practice. They had a lot of patients that would come in with a fever, right? It was not serious enough to send to the hospital, so they'd send the patient home and tell them to rest and drink plenty of fluids and that they'd feel better soon. They would use a code for unspecified fever. The issue here is they didn't know what type of fever it was. And they weren't going to do the additional testing required in order to get a more specific diagnosis code. But the payer was still denying it because it was a, quote, unspecified code, right? This is where you've got to keep in mind the payers have not done this before either, and they may get overly aggressive. So watch for that, because you'll have to educate them and remind them that that's not a correct action, right? That's not something that should be denied, right? Only the government could institute a program that's supposed to reduce healthcare expenses and then deny claims unless you do additional testing that's unnecessary for the patient, right? At least I think there's some, I see the irony in that. So keep a lookout for that, right? And make sure that you're watching that and staying on top of your payers for that. Remember what we said at the beginning. What do we want to take away here? I hope that you've learned and you've seen, and I've shown you that ICD-10 has only just begun. It's not over. There's still a lot of work ahead of us. I hope that you will be vigilant in looking for some of the problems that are coming so that you can make adjustments to your strategy. I would certainly recommend, if you don't already know, looking at the codes you're using, knowing what your unspecified rate is, knowing what that is for each of your providers so that you can start making changes to that now, right, before the payers begin to crack down, because that is certainly coming our way quickly in 2016. And then once you have that information, make sure that you do that in a way that doesn't turn your doctors into coders, right? If we want to keep our doctors happy, if we want to keep our doctors productive, we need to let them take care of patients. That's what they do best. And we need to make sure that they do that in a way that gives the revenue cycle employees the data necessary to get the claim paid completely and correctly the very first time. I hope that's helpful. I know I went through a lot of information quickly. I'll make sure that I get copies of the slides and copies of the recorded version to you once we get that uploaded. But let me stop there and see if I can answer as many questions in the last few minutes before